This week on the BackTable podcast.
For this, we don't have to do a human trial. So if you have a 510K pathway with a predicate, which means you're essentially equivalent to something that came before you, and you're not a PMA product like neuro or cardiac where it's life and death, then you can do, benchtop testing and then animal testing and then get FDA approval. And a lot of, interventional devices in the peripheral space fall into that category. So when we've met with FDA, that's essentially, the pathway that we discussed and they accepted is that we have a predicate, we have an indication for use, we do our benchtop testing, we do our animal testing, we submit for 510K, we get approval, there's an existing code. So once we have FDA approval, we can have physicians use the device in their clinics and, bill for reimbursement.
Hello, everyone, and welcome to BackTable, your source for all things endovascular and more. You can find all of our episodes online on any platform you prefer, like Spotify, Apple Podcasts, or directly through our website, backtable.com.
First, a quick word from our sponsors.
BD provides clinical education and training through the BD Peripheral Intervention Advanced Healthcare Providers courses. The BD Advanced team offers programs on advanced endovascular management of AV access, emerging techniques in the management of CLTI and venous disease, as well as many different resident programs and peer-to-peer opportunities. Contact your local BD representatives to learn more or visit the BD Advanced webpage. Now, back to the show.
I'm Sabeen as your host today, and I'm here with Dr. Ali Golshan, an interventional radiologist from Beach Wellness, MD, and founder of SOLVEIN. Welcome, Ali.
Hey, Sabeen, great to see you, man. Yeah, I would say a long time no see. It's been a minute, but great to catch up.
Absolutely, man. I mean, we're going to delve into the cutting edge of treating superficial venous disease, but, first, I know you really well, but our listeners may not know you, so let's do a little bit of intro and just to get to know more about yourself.
Sure, yeah. Thanks for having me, first of all. Really appreciate it. Love the podcast. Always great content. So I'm an interventional radiologist. I practice here in LA. I did most of my training at UCLA, college and med school, business school, internship residency. I was there for a while. And then I did a fellowship in IR at Johns Hopkins. And then I came back to LA and I joined a group practice for a year and then realized that I wanted to practice, clinical and interventional radiology. And, you're part of an awesome group. So you guys do some really, great IR. But, sometimes when you're at a group practice with diagnostics and interventional, you don't get the opportunity to do as much IR as you want. And so I met some guys in the outpatient space that had essentially dedicated themselves to minimally invasive vascular therapies. One was a surgeon, one was a cardiologist, one was a radiologist. And I joined this outpatient vascular center that primarily did dialysis work. And I brought superficial and deep venous intervention embolization to it and helped them grow their PAD program. And then from there, kind of learned the business of outpatient vascular medicine and the interventions that we didn't get to do as much of in fellowship on the vascular side because it was, interventional oncology heavy. And then started my own practice thereafter, originally with a tiny little office and then expanded the clinical office, added an OBL, and now we've added a second clinical location. And then somewhere along the path, sort of reinvigorated the innovative bug that I'd had earlier in the, business school and medical school part of my training and decided to try my hand at a startup from scratch. Yeah.
Nice. Yes. Isn't it true that one of your offices is on Rodeo Drive?
It's close. It's on Bedford. It's, I think, 3 blocks from Rodeo. It's really close to Rodeo.
Dr. 90210 right here,
Yeah, exactly. Yeah, it's a walking distance to Rodeo, but it's 3 blocks away. It's not far.
I love it. Well, we're going to get into, your startup pretty soon, but okay, people throw this term around, superficial venous disease. What does it mean to you? I mean, and then how did you really develop a kind of an interest and a passion into that?
Yeah, like many things in life, it was serendipitous. It wasn't planned. Essentially, I was at this dialysis access center and a lot of people came in with, lower extremity disease, arterial and venous. And then that access center was partially owned and managed by a company by the name of Fresenius, which is a large dialysis organization. And they had a sister branch down in San Diego, and there was a guy down there by the name of Zach Ratner who did a lot of venous therapy and is kind of an expert at it. And he did someone to cover for him. So I'd go down there and just like cover for him or hang out with him for a week every other month. And we would just like do so many complicated cases and high volume. And it kind of just got to watch him and do a high volume of cases. And I got interested in it. And, I was doing so many fistulograms and angiograms and embolizations that it was like nice to have a day or two without lead on. It was nice to have a day or two where the procedures aren't necessarily like, life and limb, et cetera, et cetera. And then I kind of got a knack for it, and I started getting referrals for simple and complicated things, ulcers, perforators, cosmetic stuff in the legs and other places. And it just kind of went from there. Yeah.
Got it. So are most of your patients now, you have your own practice. Are you getting referred? Or are they coming out organically?
Yeah, it's mostly referrals from physicians, some vascular, some non-vascular, and then word of mouth and, referrals from friends and family of patients. Don't really do any advertising, obviously inform referring physicians and physicians in the community that were available. But most of it's been physician or patient directed and organic. So we've been fortunate to be able to have, support from the community and other doctors. That's been great.
Totally. So you basically, what is your workup when you first, meet a patient? They have, let's say, pretty obvious venous insufficiency, whether it's varicose veins or a venous ulcer. What is your primary way of working that up?
The heart and soul of vascular diagnosis is ultrasound, right? Especially for venous disease. So yeah, I just get a lower extremity duplex. But when you say just a lower extremity duplex, I have the good fortune of having an RVT that's worked with me for a decade, and he's great at superficial and deep venous disease. We have the position with a patient in a standing position. We know what to look for, including the truncal veins and the perforators and the variants of the truncal anatomy, et cetera, et cetera. So thorough ultrasound examination. And on those rare occasions where we're worried about like some sort of deep venous disease and not going to go straight to venogram and IVUS, we'll get a CT venogram, but it's not a standard part of my venous workup just because it's a snapshot in time and it can be misleading.
Okay. Yeah, that was going to be my follow-up question is how often you get cross-sectional imaging, CT venogram of the belly and then sometimes the lower extremities.
Yeah, lower extremity venograms, I think, they're tough. I guess if you're like, there was a guy at UCLA by the name of Paul Finn. He's still there. He's a cardiac MR guy. Paul Finn could make a lower extremity runoff on MR just look beautiful, but he would spend, hours and all those algorithms and coils but in the community, I think like if you're sending people for like lower extremity CT venograms or MR venograms, you're gonna be disappointed in the quality of the imaging you get. And often ultrasound can get the job done below the inguinal ligament, and then the intervention. I think like if I'm doing a venogram of the iliacs and IVUS, that's when I have a patient with an ulcer or a healed ulcer, and we've exhausted their superficial venous therapy and they're still persistent. So there's a lot of exclusion criteria. So there probably is a pretty high pretest probability they have some deep venous disease. And at that point, it's like, well, I got a CT, right? Just go straight to IVUS and venogram, man.
And in your practice, you must have had experience with all sorts of devices. What are your top devices, aside from going into SOLVEIN, of using for treating, standard great saphenous venous reflux?
Yeah. Listen, at the end of the day, I think a lot of the people listening to this podcast are interventional radiologists, interventional cardiologists, vascular surgeons. These are folks that are doing very complicated procedures. And I think that the techniques that we use for superficial venous therapy are well within the expertise of these folks, and they can pick them up and whatnot. But I do think that, there's some finesse to treating superficial venous disease holistically and completely, especially in ulcer patients. But my go-tos for patients that have, truncal insufficiency, thermal works great. It's old school. It works. It's effective. RF or laser, dealer's choice. I've primarily used RF in my career, although I've used laser as well. And then for the non-thermal, non-tumescent therapies, which are basically, non-heat therapies, there's mechanochemical ablation, there's microfoam, and there's glue. They all have their advantages and disadvantages. I primarily use microfoam, and I use some mechanochemical ablation as well. Those are my personal preferences, but I think it's like if you're painting, some people paint better with a brush and some people paint better with a roller. I think these tools will work well in an experienced user's hands for truncal veins. And then once you start to get into more complicated disease, there are niche applications where one is really better than the other. Yeah.
Sure. I mean, I kind of want to explore that a little further because, in our practice, we treat a lot of, C3, 4 above patients, and we primarily use laser. We had RF before, and then we have glue. But there's definitely been times that, I want to pick your brain about microfoam and those kind of therapies, especially for like a tortuous GSV, or you have all these, random accessory saphenous veins or just accessory veins that you're trying to treat. So is that why you like the microfoam more? Is it faster?
One, I've used glue before, but I think in the course of my long-term practice, since I have a relatively high volume practice, I've made the decision that where possible, I just don't want to leave foreign body behind. There's nothing wrong with glue and it's perfectly good, but that's just like a choice I've made for my non-thermal non-tumescence. So I don't use a lot of glue. Okay, personal decision. Some people use it, some people don't. And then if you have a very large vein with a lot of venous hypertension, RF or laser, which again, I really do think are interchangeable. Well, I shouldn't say interchangeable. They're both effective and they're both thermal. We'll close that vein down, right? It'll work every time or almost every time. The drawback is obviously you got a tumor. It takes time. It can cause discomfort. It can cause skin injury. It can cause nerve injury if you go too low. And I like RF because you don't have to do the pullback, right? It's kind of brain simple.
Yeah, I like that too. I kind of missed
close.
that.
Vent close is
I
got
miss
10
like
centimeters.
Yeah,
You just press the
exactly.
button, you'll pull it back a little bit more, press it again.
Yeah.
Press it again. It doesn't quite make the turns that laser makes, but usually if it's super tortuous, I'm not using a catheter anyway, so it's not much of an issue. And you can usually get through the tortuosities. So for thermal, I don't know, I'm just an RF guy. You got both companies, they both make perfectly good products. One has the advantage of having a variable length built in, and they're both 6 French now. The competitor made a 6 French compatible catheter. So, dealer's choice, both good products. And then in terms of microfoam, I think the way I like to think of a vein is an artery is a tube of a relatively fixed diameter that takes a relatively straight course in the lower extremity, right? So even though it's not a pipe, it's kind of like a pipe. Now a vein, it's like this stretchy, tortuous, patulous, it's narrow, it's dilated, it twists and it turns, it has branches. So it's almost more like a living organism. It's like a vascular bed. It's like a stream with all these branches. And so if you're trying to treat the holistic nature of that venous disease, instead of thinking of it as a tube, think of it as like a system. And so with RF or laser or glue, we're really just putting this, cylindrical tube, whether it's thermal or non-thermal, into the trunk of that system, and we're shutting down that trunk. But sometimes if that trunk isn't isolated, there's other branches or perforators or parallel branches that aren't treated. And that's one of the advantages of foam is that it's a space occupying thing, right? You put the foam in there and it goes, and unfortunately sometimes it goes where you don't want it to go if you're not good with it, which is a dupe system.
Yeah.
And if you're good with it, then it goes to where you want it to go or where it's supposed to go. So it has infinite degrees of freedom. So it's a beautiful and a terrible thing depending on how good or bad you are with it. But I think the thing I like about it is that, again, it gives you the opportunity to treat that truncal vein or that branch or the twisty branch and the truncal vein or the ulcer bed and the veins that are underneath it, or even a perforator if you're really good with it. But of course, I'm not endorsing to use it with perforators because it's off-label, but if something you're comfortable with, there's lots of ways just to treat perforators. But it kind of just gives you that degree of freedom to mop stuff up, and it eliminates the need to use, tumescence. So those are both good things.
I always wondered, and because I'll take polydocanol and agitate it and make a foam when I'm treating perforators or some ulcer beds. But I'm wondering with Varithena and microfoam, and it's all pressurized, I'm always wondering what's your endpoint? How do you know you're not going to start refluxing through the perforators or what and go into the deep system? I still really haven't figured that out in my head as far as what volume should I use? What is it? How do you determine that?
One, it's a great question, and it's one of the things that motivated me to kind of create my company and my solution. But it was, you remember when you were a fellow and that senior attending, you're like, well, how much do you use? And they're like, you just kind of know.
Yeah.
And it's the most annoying answer in the world, And you're like,
yeah,
God, what the hell did that even mean to me? I would say less is more because physician compounded foam has a shorter dwell time and larger foam bubbles than polydocanol microfoam or Varithena. And so basically the Varithena foam is foamier, as in the little bubbles are smaller, and its dwell time is longer, which means that it's essentially more potent, which is a good thing. But if it goes to the wrong place, it's a bad thing. So physician compounded foam is more forgiving if you get it in the deep system, whereas microfoam isn't, or Varithena isn't. And so I would say if you're treating, whatever, a saphenous vein or a perforator or an ulcer bed with a perforator, use less foam to start. Less is more. And just take a look when you're scanning and see if it's preferentially going into the truncal vein of the ulcer bed or if it's dumping into the perforator and going into the deep system, and have like an active scanning technique where you're going back and forth and kind of keeping track of where the foam is going. And then if there's any concern, just stop injecting. And the other trick is that in reality, it kind of doesn't matter if a little bit of foam gets in the deep system. The problem is if a lot of foam gets in the deep system and it stays there, right? So you can calf pump, you can walk the patient. So essentially, less is more, and just start with like a simple GSV without any perforators and get a feel for like this long a vein with this much diameter takes this much foam, and this is how long it takes to get from point A to point B, and this is how long I have to hold pressure. And then once you get a feel for like how it flows and behaves, then you'll get more comfortable intrinsically.
Are you compressing the vein at all? Because we're usually compressing with thermal, or with glue. You're compressing the vein. Are you doing the same thing with microfoam, or you're kind of letting it flow?
So the idea behind the microfoam is, one, you want to elevate the leg, which works fine if they don't have like crazy venous hypertension. But if they have crazy venous hypertension, it's obviously not going to work. So you want to elevate the leg to let the blood drain out of the vein. Then the vein is smaller, so it's a smaller target, and there's less blood in it, so there's going to be less trapped blood, number one. Number two, you don't necessarily want to apply compressive and occlusive external pressure to the vein, because you do want the foam to go from point A, which would be, say, the calf, up to the groin. So you need it to let it flow. And you want to inject with a continuous and smooth injection, because you don't want pockets of foam and blood. You want a continuous column of foam to get a clean ablation. But what you do want to do is apply occlusive external pressure, below the saphenofemoral junction or above or below that perforator, to prevent it from going to the wrong place. And invariably, you're going to get a tiny bit of foam to the non-target vessel, but it's not a therapeutic amount of foam that's going to cause a DVT if it's just a tiny bit, right? I think most people worry about DVTs at the saphenofemoral junction. The reality is that the common femoral vein is pretty big. And if you're injecting from down low, it's pretty low from your injection site. I think the place where people get in trouble with DVTs is either perforators, where they're not anticipating because they don't know the perforator is there and the medication goes instead of at the saphenofemoral junction, or at the popliteal, because the popliteal is actually smaller. But you know what? Like, how the Europeans I hear have like this like ultrasound contrast agent. It's like some sort of gas bubbles or something. That's at least what I hear. Think of the Varithena as like an ultrasound contrast, contrast agent. So it's going to shine really bright because of all the bubbles. So if you follow it actively, instead of just waiting like, at the saphenofemoral junction for the foam to show up and compress, follow the foam as it goes up, and you'll see it go into a perforator that you never noticed before. You'll see it going into the popliteal when you wouldn't have otherwise noticed it. So it'll tell you where it's going. It's just kind of like a little bit of a dynamic change from thermal, because it's like an active procedure, right? Thermal, you tumescent, and then you like turn your brain off and press the button.
No thinking. Yeah.
Yeah,
you just
exactly. So
pull
no
back,
thinking,
you're done. So this just takes a lot more active role. And are you puncturing near the ankle? Are you going from there all the way up with the foam, or are you doing multiple different punctures?
If you get a tall person, it's hard to get the foam to go all the way from the ankle to the groin, number one. Number two, as you go lower, the skin becomes, there's less connective tissue at the ankle and the lower calf than there is in the thigh, and the saphenous vein becomes closer to the surface. And so what happens is when you inject the foam, it induces a thrombosis in the vein. And if that vein is very close to the surface of the skin, they'll get discomfort from thrombophlebitis, and sometimes they can get like a little bit of hyperpigmentation. So what I try to do is I try to treat like calf up if possible, and then decompress the lower segment of the greater saphenous vein. And if they're symptom-free, just leave them alone. But then if they have like an ulcer or they have persistent symptoms, then come back and do a second treatment and accept the fact that, there's a higher risk of pain and discoloration. But I kind of like to try to avoid the skinny part of the leg initially if possible.
That's great. That's a great rundown of using microfoam. That was helpful, especially for my own practice. So, I mean, we were talking about different innovative devices. So let's hear a little bit more about, SOLVEIN and what is that and how does that help us treating this disease process?
Yeah. So not FDA cleared yet. So hopefully when it's FDA cleared, we can use it in our practices, and that should be coming up shortly. But basically, just like we're talking, I was using thermal, different types of thermal, different types of non-thermal. And I thought to myself, like, okay, maybe this idea of mine could help make it better. Napkin sketch at dinner, like literally, to be cliche. And then, kind of sit on it for a little while, think about it. And then, like get in a patent attorney, file a patent. And then over time, it turned into like a real company, right? Raise the seed round, have a team of engineers, advisors, IP, prototypes, animal data, et cetera, et cetera. And the idea behind it was like, there's nothing that's ever perfect, but like, what's the iterative innovation on venous therapy, right? Like, what do I think is the next step of the next orbit? So it's like, okay, non-thermal is easier for the patient because they don't have to have saline and lidocaine injected up their thigh and their groin because it hurts. It's better for the physician because you don't have to take that time. And then you can go low because thermal can cause nerve injury if you go below the calves. Okay, great. So non-thermal, not too mess and check. Don't want to leave a foreign body behind because ideally, if you don't have to, why should you if you don't have to? No chance of foreign body infection, no chances of hypersensitivity. If someone is thin, the glue can like leave a little bump or a cast in there. And then the polydochinal microfoam, it's like technically a little bit more of a learning curve than the catheter-based therapies for superficial venous. And a lot of people that are treating, superficial venous disease aren't necessarily, doing like neuro stuff with liquid embolics or other types of stuff where, they're used to catheter-based procedures. And that gives the physician more control than the microfoam and also addresses things like non-target embolization, the foam going into the deep system and causing a DVT or failing to close the vein because it gets washed out, and things like trapped blood and hyperpigmentation and pain because if the vein is filled with blood and the foam mixes with the blood, then it induces thrombosis and you get, thrombostasis and thrombophlebitis and pain, etc. So it's basically a catheter-based non-thermal, non-tumescent without a permanent implant. And I use Clarivain from time to time. It's a mechanochemical ablation device. It's essentially a wire that spins and you inject polydochinol behind it. And so the idea of mechanochemical ablation seemed intriguing to me because you're using a mechanical and chemical combination. You're using the body's healing process to mechanical injury. You're combining with chemical. We know it works. But, it was a device that was invented a while before, and it was prior to us using Varithena and having our experience with foam, and it has its own limitations. So, how do you improve on that? And essentially, SOLVEIN, the product, it's a catheter with a compliant balloon, like a Fogarty balloon, essentially, a compliant balloon that when you inflate that balloon, unlike an angioplasty balloon, its intent isn't to be hard at a fixed diameter. Its intent is to be soft, but at variable diameters, right? And so you essentially insert the catheter via a sheath into the saphenous vein of your choice, the target vein, and you inflate the balloon under ultrasound until it makes contact with the vein wall. And then there are some nitinol wires draped over the balloon. And then once the nitinol wires and the partially inflated balloon are making contact with the saphenous vein, you advance the catheter from, say, the calf upwards towards the saphenofemoral or saphenopopliteal junction. And as you do that, you get circumferential vein wall injury with the balloon and the wires. So you're causing endothelial denudation. You're causing vasoconstriction. So you're making that vein go from big to small. And one of the issues with the existing mechanochemical ablation device is that it spins at a high RPM and it can get tethered to the vein. It can get stuck, right? This isn't that. It's essentially, a compliant balloon with some wires on it. So when you're advancing it up, there's really no issue with it spinning and getting caught in the vein. So it addresses that shortcoming. And then when you get to the top of the saphenofemoral junction, you hyperinflate the balloon, it becomes occlusive. And then you separate the deep and the superficial system, which the existing mechanochemical ablation device doesn't do either. And again, when we're talking about microfoam and we're talking about the foam going into a perforator or the deep system, at this point, that occlusive balloon has isolated the superficial from the deep system. And then you aspirate the blood out of the isolated saphenous vein with an aspiration port. Well, the vein's already vasoconstricted, but you take that blood out, and the blood is the enemy, right? Because blood actually deactivates polydocanol or other sclerosants. And also, that blood dilutes the medication. It washes it out. And then the other thing that happens is when the medication makes contact with the blood, it causes thrombosis. And that thrombosis is what causes pain and hyperpigmentation. So a bloodless field is your friend. And then you inject, a physician-determined substance, physician-compounded foam of the doctor's choice, essentially. And then that foam comes back. It hits that occlusive balloon distally and comes back and works its way back. And now you essentially cause mechanochemical ablation of the vein, and you've got the advantage of the foam, but you're controlling the foam, and you're synergizing the mechanical injury with that foam ablation.
When you're injecting, is it injecting from the position of the balloon or from your access site?
The position of the balloon. The aspiration infusion port is just proximal to the balloon. So the medication comes back. Yeah. So it's not from the access site. Yeah.
That's pretty neat. I mean, and you mentioned vasoconstriction. I would imagine that pushing that balloon up and while you're causing vessel injury is going to, the saphenous vein can really spasm down.
That's what we want, right? If to ablate a 10 millimeter vein is hard, to ablate a 3 millimeter vein is easy. So if we can induce vasoconstriction and epithelial denudation and get that thing to wink down, less foam, less blood, less hyperpigmentation, easier to kill.
Does the balloon ever not advance because it's so vasoconstricted? It can easily go.
Because we're inducing the vasoconstriction as we go up. So the vasoconstriction kind of trails behind the balloon. And you do a lot of DVT work and stuff. If you're doing an up and over, you hit the valves. But if you're going from down to up, you're going the right way of the turnstile, so you're not going to get stuck yet.
Yeah, that's pretty neat. And then can't whatever foam you inject, can't it then leak through the perforators?
So the perforators are usually in the calf of the ankle. So the foam comes from the top down. So the last place that the foam sees is the perforators, right? 1. 2, it's physician compounded foam, so it's less powerful than the Varithena foam. So it's less likely to seep into the deep system and cause a DVT. Number 3, the perforator has a junction with the greater saphenous vein. It's the perforator saphenous junction, essentially. As you're kind of steamrolling over the endothelium and the saphenous vein and inducing vasoconstriction, you're going to kind of cause it to wink at the junction. And then number 4, before you inject the foam, you aspirate. So you're kind of creating a negative vacuum. So it's going to be less likely to go into that system. So theoretically possible, but very unlikely. And I did a lot of foam, physician compounded foam, sclero before we had Varithena. And in my experience, never had a DVT. The physician compounded foam is forgiving. Because it is less
I know.
potent.
I've seen it go places and I'm like, oh God.
And it's fine, right?
They pump the calf. Yeah. Pump the
exactly.
calf. Yeah.
But the problem is that by itself, physician compounded foam doesn't have the potency to cause an acceptable level of truncal vein ablation, hence the indication for Varithena. But here we're combining physician compounded foam with mechanical, and hence it gives you the efficacy that's acceptable, but the safety that's desirable. Yeah.
And when you have the balloon up, you're injecting your foam. How long do you have to leave the foam there and then until you
2
take
minutes.
the balloon down? 2 minutes, then you just take the balloon down. By then, the potency of the foam goes away. So you just take the balloon down, just take it out, and you're done?
Yeah. Saves you some time.
Yeah, I like this. I love the concept.
Thanks, Boo.
Very nice napkin idea for sure. That makes
there were many iterations with the engineers before it got from my ugly napkin sketch to its current existence.
And yeah, so when do you expect this device to be available? When is your hope?
Yeah. Hopefully in less than a year. Maybe maybe you'll use it in your clinic in 9 months.
That's awesome. Is it what's the process? Was this a whole learning process for you too about developing the device now? What's the next step? You have to do a human trial then once to get the FDA approval, no?
For this, we don't have to do a human trial. So if you have a 510K pathway with a predicate, which means you're essentially equivalent to something that came before you, and you're not a PMA product like neuro or cardiac where it's life and death, then you can do, benchtop testing and then animal testing and then get FDA approval. And a lot of, interventional devices in the peripheral space fall into that category. So when we've met with FDA, that's essentially, the pathway that we discussed and they accepted is that we have a predicate, we have an indication for use, we do our benchtop testing, we do our animal testing, we submit 510K, we get approval, there's an existing code. So once we have FDA approval, we can have physicians use the device in their clinics and, bill for reimbursement.
Yeah. And your on label is going to be like great and small saphenous veins, basically.
Yeah. The indication for use is a catheter for the delivery of physician determined substances in the superficial vasculature, saphenous veins. Exactly.
Very cool, Ellie. I think that's an exciting time for you too. So congratulations to getting this far. I'm sure it's going to, next, I'm excited to see this device come onto market. I mean, it seems like the learning curve, for you, have you had people in your testing now that hasn't had experience with microfoam find this pretty easy to use? Meaning, like, is the learning curve pretty good? Because for you, it's hard. Your bias, you have, crazy dexterity in this as you've used all different devices. But say someone like me who's not used microfoam, is this going to be like quite a learning curve, or is it going to be pretty easy?
No, when I've talked to, people that are on board that are, luminaries in vascular, whether it's venous or not venous, and talk to friends and acquaintances and done animal testing and put it in the hands of animals of, a non-physician, I think most people agree that it's pretty simple to use. And the learning curve is, pretty straightforward, right? It's a balloon catheter and you got to aspirate and then inject. We tried really hard to make it as simple with as few moving parts and syringes and ports and blocking things as possible. We just really tried to whittle it down to basics and minimums. Just because, like you said, I think one of the biggest things with adoption is just ease of use. Like if you look at, say, intravascular lithotripsy, it's a balloon on a button, right? And that really helped adoption versus some of the more complicated devices, whether they're in whatever niche, and you're just kind of all right, what do I plug this into? And what do I do with this button? And what goes wrong if this happens? I think all of those hurdles are just kind of barriers to physician adoption and utilization. I guess sometimes you just have to have them, but simpler is better than complicated. Yeah.
Has this opened up Pandora's box for you? Is this going to be your one and only device, or your mind is turning?
No, there's a little black network, and I'm just waiting to. Yeah. I'm
awesome.
excited, and it was a exciting first time, and it made a lot of great friends and contacts. But yeah, I think the first time as a physician entrepreneur, any kind of entrepreneur, you're kind of learning where the different parts of the room are in the dark. You got to find your patent attorney, you got to find your engineers and your contract manufacturers and your quality system, all the gibberish of this new alphabet that we don't know about. But I think once you kind of have done it once or twice and you know where the parts are, it doesn't mean it's going to be easy the second time, but at least you've got your people and you know where the different things are, and definitely makes it less.
No, that's awesome. And anyone out there that, you want to give any words of wisdom to anyone out there?
One, file a provisional patent. It's very inexpensive and it's very quick, and it protects your idea and it gives you a timestamp on it. One. Two, practice good data hygiene, right? It's very important to share the information with people you trust, but don't go, telling people that there's no point in telling, right? Number three, find mentors that are, receptive to you, but have been successful doing whatever it is that you need them to do or that you want to do in the past. Don't be one of these people that's I'm not going to tell anybody about my idea. You don't tell everybody, but you do need to tell some people, and find those mentors. And if it's not a good fit or it is a good fit, then ask for more introductions, right? So that's how you build your nodal connective tree, and you make your network and share ideas with people and be helpful, right? Maybe your buddy's a VC and he wants to due diligence, a product, or there's an attorney that needs a question answered. Make your friends. Don't be insular and isolated like we sometimes are as clinicians. build your network, spread your wings, go to non-medical conferences, go to startup conferences, just meet people, learn. And, if it's for you, great. And if not, then you made some friends.
Well, Ellie, thanks for coming on. That was a really informative episode. And honestly, I'm really looking forward to seeing where SOLVEIN goes and where you go too. That's pretty awesome, man. Congratulations.
Thanks, man. I really appreciate it.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabeen Dhand,
Michael Barraza,
And Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.